Okay, so Eric, thank you so much for being here with me today.
Yes, thank you
For,
for having me.
for listeners, this video is part of the ASRA Resident and Fellow Committee video interview series on recent fellowship graduates. So quickly, I'm just going to introduce myself, and then Eric, I'll have you introduce yourself. My name is Chelsea. I'm one of the co-chairs of the Career Development and Networking Subcommittee. I'm also a current regional anesthesiology and acute pain medicine fellow. So I'm very excited to have this discussion with Eric today. So Eric, can you go ahead and introduce yourself, including your fellowship specialty that you pursued, your institution, and what you've been up to since graduating?
So I'm Eric Reilly. I did my fellowship at the University of Washington in Seattle in regional. And now I signed on as an attending back where I trained for residency at Corewell Hospital in Royal Oak, Michigan. Um, I finished up at the end of August, and since I've just sort of been traveling a little bit. I was at a wedding in Portugal and catching up with the wife. She's in residency here in Michigan, so we were apart for a year. So it's nice to be back with her and going to some conferences. I was at the ASA conference and a couple of things. So and took my oral boards. So yeah, just a lot of exciting stuff in the last couple of weeks.
Well, congratulations on graduating and also on getting through the oral boards, because that
Thank
is
you.
looming over me at this point in life.
Yeah.
Okay, so getting started, can you describe a day in the life of a fellow at University of Washington?
Sure. So it's a hybrid model. It's non-ACGME, so you're half attending, half fellow. And the fellow days are variable because you can be at a couple different sites. You can be at one of four different sites. There's Harborview, which was one of my favorite sites because there's a ton of trauma that comes through there. It's one of the major trauma centers in the Pacific Northwest. There's the UW main hospital, which is Montlake. And then there's two ambulatory centers that we also go to. I'd say I was probably at Harborview the most, where I was based at. Typically, you show up around, like 6:30. Kind of start cranking through the first case blocks and pre-op. Depending on what kind of role you want to take that day, you might be doing some blocks, on your own if it's very busy. You may be teaching residents. If there's some more complex, like weird things you want to learn, you may be paired up with one of the regional attendings who's kind of walking you through their tips and techniques. So the day was really, I think every fellow day was really like make it what you want, which I love. There was a lot of autonomy when you wanted it and a lot of direction when you wanted it. And yeah, I mean, it was great. Typically, I'd say on an average regional day, I was maybe getting out of the hospital sometime between like 2 and 5, sometimes a little earlier, usually never later than 5. It's just, you never know what's going to come in. You never know what trauma case or something's going to come in or what floor cases in the ICU are going to need a block. So it was a pretty big window, but it was always active. It was always fun.
Very nice. It sounds like it was a great balance between doing your own blocks and really becoming an expert with regional techniques, but also with teaching and some of those administrative roles that comes with being a regional anesthesiologist. So that sounds very good.
Absolutely. I loved it.
Very nice. What kind of rotations did you do during your fellowship year?
There weren't strict rotations. So there was, you'd have your regional days at Harborview, which was a trauma hospital. So a lot of times we would round with the acute pain service. We'd do blocks on the floor, doing a lot of body blocks and techniques to try and wean people off ventilators. Blocks in the ICU. There's a lot of, chronic pain issues and opioid substance abuse issues of patients coming into Harborview. So working hand in hand with the acute pain service was awesome because like we were always offering up blocks to get those people on the right track, on the right protocol of their multidisciplinary pain team. It was amazing. They've written so many great protocols. And then around the ORs, just a little bit of everything. Sometimes blocking these trauma cases coming in, super complex, like horrible, cardiac patients who can only go under a regional anesthetic. So just really interesting cases at Harborview. At Montlake, I was there probably the second most as Harborview. A little more standard. You do some different blocks because there's certain surgeons which like certain lower extremity blocks or upper extremity blocks. So you get a little bit different taste. Not so much like trauma and floor stuff coming in, although like a lot of thoracic epidurals on the floor, helping wean patients from the ventilator after lung transplants. Um, and uh, and then at the outpatient centers, like you never know what's good. It's just random stuff comes in. Usually it's pretty like standard upper lower extremity blocks. And a lot of times you're helping out a resident or like teaching the resident how to do them. Um, or if it's busy, you're doing some on your own. So I think it was a really good mix, and I got to see like all aspects of regional and what I wanted.
Very good. And it sounds like in addition to the regional techniques, it sounds like you also spent a great deal of time on the acute pain medicine service, which, is very important too. It's kind of the other half of this fellowship specialty. So it sounds like you got a very well-rounded experience during fellowship.
I did. And everyone says in your residency, like, they say train fellowship somewhere else, get out of the dogma or the expectations of your state or your home institution. And I'm so glad that I did, because the way they approached acute pain was so much different than, how it was approached at my residency. The acute pain service at Harborview was like this multidisciplinary, like they had a psychiatrist, they had the, chronic pain doc, they had our regional team, they had like NPs, they had residents, they had so many people like together, and they do these big table rounds talking about these super complex pain patients, on these crazy opioid therapies or on or off methadone or this or that, like, and it was really just brainstorming of like, what do we do? And it was really novel, and they have such a great program there. It was really eye-opening to me.
I'm really glad you were able to have that experience, especially doing fellowship elsewhere than where you trained residency. I think that is great advice for potential applicants looking forward.
Yeah, yeah.
What did your education in didactics look like at your institution?
I'd say it was variable. I think that, there's probably, since it was non-ACG me, there's probably programs out there that are stronger in that regard. In fact, I know there are programs out there that are stronger. Every day after morning blocks were done, we usually about like an hour of downtime. And often we would either the regional attending would present on the topic, or one of the fellows would present on the topic, or one of the residents, if they really want to talk about something, would present. So, but that was very informal, just sort of like talking about stuff, sharing ideas. And then we would do journal clubs usually about every 2 months, where the fellows would present and just spark up great discussion. It was always at one of the attendings' houses. It was a great time. And then, just like kind of during the day, a lot of teaching, a lot of attendings who are eager to teach. But I wouldn't say there was ever an actual classic, like sit down in front of the screen at this time, like we're talking solely about regional. Now, being an academic institution, you'd have had amazing, grand rounds and lectures like every single morning, every single day about a million different things. And oftentimes the topics were regional or something. But as for something that was solely like only for the regional fellows, there wasn't like a strict show up at the auditorium at this time, you're watching it at this time. So it was a little more informal, I'd say.
Got it. Got it. So a little self-direction and also kind of going over the topics that you and the residents wanted to go over. So it sounds like there's a lot of flexibility in the
Oh
topics
yeah,
we're discussing.
yeah, big time.
Very good. Did you have to take call? If so, what did your call schedule look like during fellowship?
There's no call. There was the residents cover like following up on the blocks over weekends or overnight and stuff. So as a fellow, we did not take any strict regional call. We did have as an attending, every once in a while you may have been assigned like an overnight shift or something. But as a fellow, we didn't pick up any call.
Okay. Okay. And you did mention that you were in a non-ACGME accredited fellowship and therefore were working kind of half as a fellow, half as a staff. What did that split look like for you?
The split was actually a very friendly schedule. 2 days a week you were a fellow, and 2 days a week you were an attending, and 1 day a week was your academic day. And then most weekends you were off, or you always had the option to pick up extra shifts, and the money was great as a staff, as an attending if you wanted to. And you had to work, I think it was 2 weekend shifts per month. That was like your quota that you had to work. And so there's a lot of free time, a lot of time for research, whatever you want to do with your academic day, research or whatever. And I mean, I loved it because I personally, this was just me, I didn't want to go a whole year without really getting into the OR. I was like, I got oral boards coming up, the applied exam. Like, I want to make sure I stay up on my skills. Um, and so it was the perfect mix of me of doing a ton of regional, getting the stuff that I wanted out of that, and then also easing into this role as an attending anesthesiologist, and doing that, 2 days a week, and usually more because I'd often pick up extra shifts because I loved it. And so yeah, it was great. And then with my academic days, I got really interested in POCUS. So over the course of the year, I got my POCUS certification through the ASA, and did a ton of teaching and stuff like that with the residents, and made a couple posters that got presented with some of the residents. And it wasn't until the very end that I got the opportunity to write a book chapter. So now I'm writing a book chapter that'll be published next year. So just like awesome opportunities left and right, and a very open schedule to make it what you want.
Yeah, well, that is very impressive. It sounds like you were very busy during your fellowship year, exploring a lot of different academic, kind of scholarly activities. So that is really cool, having the opportunity to be able to do that and pursue those things like POCUS, and your book chapters and presentations and everything, as well as getting used to being an attending, and preparing for oral boards. So it sounds like a very busy schedule, but it sounds like you're able to kind of accomplish all of those things within the year.
It was, it was busy, but in the moment I felt like I had so much downtime, because my wife was in residency at University of Michigan, so we were apart for most of the year, and just sort of being in an apartment in Seattle, I'm like, well, I don't want to just sit here. Like, I got to do something. So yeah, like I just tried to stay busy. And when I wasn't doing stuff with the hospital or with medicine, I did a ton of hiking out there. I mean, Pacific Northwest, in my opinion, it's like one of the most beautiful places on the planet when it comes to hiking, backpacking, accessibility. So yeah, it was a super fun year.
Yeah, that sounds incredible.
Yeah.
So in terms of the regional experience, so you touched on it a little bit, but kind of more specifically, did you keep track, like how many nerve blocks were you performing? What types of nerve blocks were you commonly doing? And what types do you feel like you didn't get as much exposure to?
I thought you were going to ask something like this. So I did some quick math a couple minutes ago. I think I would say I either did or directly supervised roughly like 1,000 blocks. Um, and then as for types of blocks, I mean, I kind of touched on it earlier. I would say at Harborview, it was very fun rounding on the floor with the acute pain service, and doing, some of the like truncal blocks and stuff to help with big, big incisional pain, or whatever you have, or big traumas or something, to try and alleviate these patients or whatever was going on, whether they're on the ventilator or something else was going on. A ton of your bread and butters, a million femoral blocks and pop sciatics and superclavs and infraclavs and axillaries. We didn't do many axillaries in my residency. I did a lot out at Harborview, and that was really cool for me to learn. I mean, a zillion PEX blocks I'm obviously not naming them all, but yeah, it was a really good variety. I can't think of something I didn't do at least once or twice.
Okay, very good. So it sounds like, upper extremity, lower extremity, peripheral nerve blocks, truncal nerve blocks, abdominal nerve blocks.
Yep.
Sounds like you were able to see pretty much a little bit of everything. So that's
And what
very
I
good.
love, the surgeons a lot of surgeons were very appreciative of the block surgeries. Oh, and it's a major burn center, so we'd have these patients coming in getting like extensive debridements and donor sites for these burns, and we'd go in, we'd like glove up and do a sterile block like intraoperatively, like as soon as they harvested or did the graft or something. And if there was enough time, sometimes in pre-op, we'd do our block, we'd come back, 20 minutes later, um, test it, and then outline the area that was covered, and then the surgeons would directly take from that outlined area. So like that was really cool with all the burn surgeries and scrubbing up and going in intra-op and blocking with them. And that was another really cool thing I liked.
Yeah, that does sound very interesting, kind
Yeah.
of just mapping out, like you were saying, mapping out the innervation area and seeing how much your nerve blocks were, helping these patients and getting kind of a real-time feedback into what service you were able to just offer them. That is very cool.
Yeah.
In terms of, getting towards the end of your fellowship, or maybe you did it earlier during your fellowship year, but in terms of the job search process, I know you mentioned that your wife was back in Michigan, so I'm sure that played a role into deciding where to work. But what did your job search process look like? How did you decide to go into, how did you decide between private practice and academia? What did that look like for you?
Yeah. So I'm even to better answer, I'm going to back up one step. When I was still in residency and people were talking about like fellowship, no fellowship, the job market's great right now. Like nobody is going to argue that the anesthesia job market's amazing right now. What I heard, the stories I heard as a medical student were, there's certain places that only hire fellowship trained docs, and there's some places that may not strictly adhere to that rule still, but still, if you want to come in, a lot of times they'll be like, okay, well, you're going to we'll create this fellowship for you. You're going to be this random fellow, and then you're going to come on as full staff or something. So the having a fellowship is still very attractive to a lot of places. And despite the job market being very good, I kind of noticed, and some of my mentors were telling me, 3 years ago, you could get any job you want anywhere in the world, like it didn't matter. Now, a lot of the really great jobs or more competitive jobs are kind of getting saturated. And so, like in my group, I was the last person hired. Now we're at full staff, and so these jobs are starting to fill up. And with my wife being in residency and maybe wanting to go academics or not knowing where she's going to end up, I just didn't want to close any doors. If she has to move to a city and the best job nearby is some academic center that only hires fellowship trained people, I mean, I'm not in 10 years, I'm not going to go back and do a fellowship. I just can't get that job. And so I wasn't sure what the future was going to hold, and I didn't want to close any doors. And I noticed that a lot of the people who were in positions that I liked, people who were heads of, quality, people who were chairs of department, people who were very involved at the state or national level within organizations, all had fellowships. I was like, that's not a coincidence. Like, that sets you up for something. And so I wanted to keep those doors open. Hence, why I pursued a fellowship. Now, the job market after the fellowship was awesome. I mean, everyone was offering jobs. Hey, we got a job for you. I'd meet someone at a conference. Hey, yeah, call me, email me. Like, we'd love to have you on staff. And I approached it geographically at first. Said, well, my wife's going to be in residency for 2 more years, so I looked basically anywhere within 2 hours of where she was in residency. I was like, I can make a commute if it's absolutely worthwhile, or I can, spend some time away. So I cast a huge net, just started emailing people I knew, contacts, and everyone commented on the fellowship. Everyone's like, oh, you're regional trained. Like, yes, we do so many blocks. We have a lot of our older docs who are less comfortable with blocks. Like, we really need someone to come in. Like, are you comfortable going to an ambulatory center? Like, would you be comfortable covering up? Like, because these surgeons need these blocks for these same day cases. Like, so every single person I talked to was very, excited about the fellowship, because they want, I think in today's day and age, with how, surgery is minimally invasive and so many things are going outpatient, it's all about same day and ERAS protocols and less pain. Like, regional is becoming intertwined into every single type of case. And that appeal is so attractive. Having that skill set, I think, is so important moving forward. So I only saw it as adding to any of my prospective job opportunities. What it came down to for me was where I trained for residency was only a half hour away from where my wife and I are living. It was the one of the best contracts in terms of pay and vacation, and so it was kind of a no-brainer for me. I was like, I've been there, I trained there, I know the hallways, and that it was a pretty unanimous decision after I kind of talked to everyone. But yeah, it was very fun. I think the job market is really good right now. I hope that it stays that way. But I mean, you never know what's going to happen. There's crazy things happening in anesthesia with practices merging and staffing models changing, and some people moving to models where they might have less docs and more CRNAs or something. So I think anything you can do to protect yourself and your skill set and say, hey, look, this is what I bring to the table. I'm a regional anesthesiologist. I can do any of these blocks. I can head up committees. I'm POCUS trained. Anything you can do to separate yourself is going to protect your job in the long run, is my opinion and what kind of people have told me over the last couple of years.
Yes, and thank you so much for going into that, kind of the reason to decide to pursue a fellowship and to pursue a regional anesthesia acute pain medicine fellowship in particular. The job market, like you said, for general anesthesiologists has been so good for years, but you're right, those jobs are becoming more saturated. And people, with the way that medicine is moving and the way that with these ambulatory surgical centers and how priorities are changing, regional anesthesiology is huge, and I think it will only continue to grow, and people will continue to seek doctors who are trained in regional anesthesia and are efficient and reliable with their blocks. So I think thank you so much for touching on that, because it is such an important thing to consider for our graduating residents, to see if this is something that they might be interested in, and I think it can only help them in their careers.
I totally agree. And you used a really important word there. You said efficient. A lot of people can do a block. If it works and how quickly you can get it done are two totally separate things. And there were so many times, where you'd have a surgeon who was in such a rush and they're like, I don't have the time. We can't do a block. Just give them Dilaudid. They'll be fine. And it was when one of the fellows would come through and be like, look, I can get this block done for you in 8 minutes. Just let me grab the ultrasound. When we streamlined or worked with them, I can scrub up, I can do it intra-op, or I can do it immediately post-op, just right before they wake up. We would work with them based on the scenario and the patient, the situation, and being efficient like that is one thing that I think you really take out of the fellowship, which is so important.
Yes, definitely. Efficient, reliable blocks, I think, is paramount.
Yep.
Okay, so I think we're nearing the end of our time, but what type of advice or what recommendations would you give to current residents or prospective future regional anesthesiology and acute pain medicine fellows? What would you tell them?
I would say, my program director in residency always used to say, have a fire in your belly. He used to say, want to do more than the person next to you. I think you don't know where the field of anesthesia, a lot of fields of medicine are going to go. Just try and be a yes person. Just try, and if you have the time and the effort to put into something, especially even if it's out of your comfort zone, try and dive into it. Whether that's research or engagement with an organization or advocacy or a fellowship or something, a POCUS, I would say just try and be the best anesthesiologist you can be. Always remember that your patients come first. All this other stuff is very exciting and entertaining, but you need to really focus on being an excellent anesthesiologist for your patients, and then the extra stuff comes. And communicate. There's so many resources out there through ASRA and through ASA and all of these organizations that want to help you and want to connect you with like-minded people. And I promise that there is somebody out there and some practice who has faced and overcome the problem you are going through right now. So be open to new opportunities, be open to communicate, and just be the best scholarly anesthesiologist you can be. And I think it's going to provide you with a really fruitful, rewarding career.
Well, thank you so much again, Eric, for being here. I thought this was a wonderful discussion. I think we touched on many different aspects of what fellowship looks like and what your experience was like. So I really appreciate you being here today. Any last, parting thoughts or anything?
No, thank you so much for having me. And I hope to see a lot more regional anesthesiologists in the world soon.
I agree. Me too. Thank you so much, Eric. That concludes our video interview with Eric Reilly, a recent acute pain and regional anesthesiology fellow from University of Washington. Thank you so much.
Thanks. Have a good one.